Hi, I'm Kiana, and this is week 5 of pharmacology tutoring for Southwest College of Naturopathic Medicine. And this week we're going to be talking about hypothalamic and pituitary drugs, which are generally really similar to the hormones that are produced. So if you understand the hormones, these should be pretty easy for you. So before we go through the drugs, I'm actually going to go down to this table. I think Dr. Yalda puts this into your notes as well. It's from your textbook. One thing to point out, I feel like it was made just a little bit backwards, at least for my brain. So remember that the hypothalamic is what's controlling the pituitary, then it acts on an organ to do something else. So what I mean by that is the hypothalamic hormone, say for example, thyrotropin releasing hormone is released first from the hypothalamus. It then stimulates the anterior pituitary to release TSH. TSH will act on the thyroid to release thyroxine and triiodothyronine, so T3 and T4. So remember, it goes hypothalamus, pituitary, target organ, and then a hormone is made. This image, which is also provided to you in your notes, is actually pretty nice. You can see what hormones are coming from the posterior pituitary as well as the anterior and their target organs and what comes out of it. And this is a great image. I got mine from Merck manuals actually, so if you just Googled this image, or you could just copy paste it from the notes as well. All right, let's get into it. So hypothalamic and pituitary drugs. So a good thing to know is that prolactin, which helps produce milk, anti-diuretic hormone, and oxytocin, which helps secrete milk, they're working directly on an organ, and other hormones don't work quite so directly. But these three will all work directly on the organ. It's good to know for quizzes and such. Might come up at you. So the anterior pituitary, good one to know. Growth hormone. I forget what this baseball player's name is, but in the mid 2000s, I think it was like 2007, he got caught using growth hormone as kind of his form of like doping, and that was really unheard of at the time, using growth hormone to improve your performance. And they actually caught him. I do believe he grew in stature, which is kind of abnormal for a man in his 30s. So I think he grew like an inch or an inch and a half, and they caught him. But as you can see, he was playing for the Diamondbacks. Great. This is a nice little schematic as well about how growth hormone works to not only increase like body mass, it's going to make lean body mass greater. It also works on the liver, and the liver will produce more insulin-like growth factor, which leads to bone growth, linear growth, actually. So lean body mass, IGF-1, bone growth, all tied to growth hormone. So you can use growth hormone in children who are underdeveloped, it's a very common use, or adults with HIV/AIDS lipodystrophy, so people who are kind of wasting away from having AIDS infection, they can be given growth hormone to kind of stop that wasting. It's now used in anti-aging medicine, and it's commonly abused by athletes now, and sometimes normal-sized children in athletics may be given growth hormone, and that is abusive. So antagonist uses. So we're going to want to block growth hormone in these diseases: acromegaly, gigantism, and cancer. Acromegaly and gigantism, they're both pituitary adenomas that secrete growth hormone, but acromegaly is in an adult, so they're going to kind of get like these older looking features. And gigantism is in a child when they have a pituitary adenoma. They're going to just grow very, very, very tall. And cancer, we're trying to suppress the amount of growth hormone going to that tumor cell. Some side effects can be diabetes, carpal tunnel, edema, joint pain, Hodgkin lymphoma. It's a really interesting side effect of growth hormone. Hypoglycemia, which makes sense. You're probably going to burn through all of your body's stores of glycogen and your blood sugar faster when your body's trying to grow. And acromegaly, which is like the adult form of having too much growth hormone. Usually this is caused by pituitary adenoma, but if you're a normal adult who starts abusing growth hormone and you have too much growth hormone, you could get acromegaly. It's important to remember that somatostatin is what inhibits growth hormone. And I remember it like somatostatin because you want to stay, usually. You don't want too many things going on. I feel like somatostatin usually helps kind of mitigate some of our hormonal responses as far as satiety and even growth hormone. HCG. So it's used in the first 8 to 10 weeks of pregnancy, and it's actually what's picked up on a pregnancy test. And it maintains the corpus luteum, which is normally producing progesterone, and it's maintaining that corpus luteum's progesterone until the placenta can take over to produce progesterone. So HCG is kind of keeping that corpus luteum alive, so more progesterone can be there until the placenta is big enough to produce it. HCG can also help regulate luteinizing hormone and FSH for spermatogenesis, so it can be used in males too who need help regulating their luteinizing hormone or FSH. It's used to diagnose infertility, and like I said, it's used for pregnancy testing. And in an ectopic pregnancy, you'll have HCG, but HCG will be lower than expected. And that's one sign of ectopic pregnancy, is that you have the HCG, but it's not as much as you would expect. And HCG can be abused for weight loss. It's used in reproductive medicine and can lead to multiple births. So people who are having quadruplets may have had some HCG involved. Gonadotropin releasing hormone. So this is going to increase the gonadotropes, as you would expect. So this is actually a hypothalamic hormone because it's a releasing hormone. So it increases FSH and LH from the pituitary. It's used in reproductive medicine. It's also used in cases of infertility, like reproductive medicine typically aims to fight. And gonadotropin releasing hormone can also induce puberty in those children who are having trouble developing. It'll help them release more gonadotropes, so then they can start to develop a little bit more fully. So it can stimulate the gonadotropins if it's used one time or kind of sparingly, or if you use it long-term in multiple injections, it can actually cause that feedback and suppress gonadotropins. An antagonist of FSH can be used as a male contraceptive. This is because it decreases spermatogenesis, but testosterone, which is controlled by luteinizing hormone, will remain unchanged. So antagonizing FSH can reduce the sperm that's being made, but it won't mess up their testosterone because that's controlled by luteinizing hormone. So remember, blocking FSH can block spermatogenesis, but it won't mess with the testosterone. As where if you blocked GnRH, you would be messing with spermatogenesis and testosterone. Prolactin. So prolactin is an acidic hormone. That's good to know as well for your boards, which I'm taking mine in 3 days now. So that's kind of exciting. This is good review. This will keep coming back at you. Prolactin is inhibited by high dopamine. So dopamine is going to inhibit the secretion of prolactin. It's used for milk production, and I like to remember prolactin production. Hyperthyroidism can induce high prolactin, and that's because TRH, thyroid releasing hormone, also stimulates prolactin release. So having hyperthyroidism, if your TRH is high, your prolactin's also going to be high. So bromocriptine is a dopamine agonist. So bromocriptine is increasing the dopamine. This will suppress prolactin in patients who are having a hyperprolactinemia. And remember, the most common pituitary adenomas are prolactinomas. So if someone's producing too much prolactin, they're going to have low libido. They're probably not going to be menstruating. They might feel kind of down actually too. And having that high prolactin can be inhibited by increasing the dopamine. So giving them bromocriptine as an agonist for dopamine will stop all of those high prolactin symptoms. Antipsychotics, which aim to lower dopamine, and estrogen can also stimulate prolactin secretion. So remember, high dopamine, low prolactin. Low dopamine, high prolactin. They work in the opposite directions. So that's everything for anterior pituitary. Now let's talk about the two guys in the posterior pituitary. Oxytocin. So it's good to remember that oxytocin, I remember milk out. It's responsible for the milk letdown. This is what helps breastfeeding take place. And prolactin's what makes the milk be produced, but oxytocin is what gets the milk out. It also kind of gets the baby out. It stimulates uterine contractions and the milk letdown. So it can be used to induce labor if the mother's having some complications or if they've kind of had a protracted labor where it's taking too long. So it could be used in situations too where there's maternal diabetes, that's pretty bad, preeclampsia, which is hypertension, and eclampsia is, without the pre part, is when they actually have hypertension and seizures. So we'll want to get the baby out sooner, and that's why oxytocin is used in these patients who have preeclampsia. It can stimulate ADH at high concentrations and cause fluid retention. Remember, anti-diuretic hormone makes you hold on to more water, and this will lead to hyponatremia. Hyponatremia because you're watering yourself down. You're not going to have as much sodium in your blood when you're watering yourself down, and that gives you hyponatremia. It can cause heart failure, seizure, and death, and injections can cause hypotension. And antagonists can be used in preterm labor. So if the woman's going into labor too early, we can try to block that oxytocin and stop the labor from coming on too early. Anti-diuretic hormone, also known as vasopressin. This will bind the V2 receptors in the kidney, and it increases water reabsorption. So you're going to keep more of your water. You're not going to be peeing as much with anti-diuretic hormone. So desmopressin is an agonist, and this is used in diabetes insipidus and hemophilia. So this would be used in neurogenic diabetes insipidus, and that's because the patient isn't producing enough antidiuretic hormone in neurogenic diabetes insipidus. So giving them an agonist, something that acts similarly like desmopressin, will give their body some antidiuretic hormone to work with, and they won't have diabetes insipidus anymore. They'll be able to reabsorb water with desmopressin. It's also used in hemophilia because these patients tend to bleed a lot, and if they have a major bleeding episode, it can help to preserve some fluid volume for those patients if they're given ADH. Antagonists can be used to kind of get rid of edema in patients who are holding onto too much water. So if we block ADH, we're not going to hold as much water. We're going to be okay with diuretics if we're not having antidiuretics. So antagonists of ADH can be used for edema or to treat SIADH, which is syndrome of inappropriate antidiuretic hormone. It's also used to treat hyponatremia and heart failure. So if you don't have enough solute in your blood, you're probably holding on to too much water. And if we antagonize ADH, we're going to be able to get rid of more water and hopefully dilute your blood, so then you're normonatremia instead of hyponatremia. And heart failure patients often have edema, so that's why antagonists of ADH are commonly used in heart failure. And I would really just encourage you to get familiar with these schematics, know what the end organ is, know what's stimulating the hormone, and what the hormones are doing for us. It's all really high yield for your boards and good to know if you're ever going to treat patients. Honestly, even if you're not doing hormones, really good to know, so you can watch for those patients who could be having these issues. If you guys have any questions on hypothalamic or pituitary hormones, feel free to send me an email. I might not reply quickly this week, but we're all here to help you.